Hello and welcome. Today we're diving deep into a fascinating and sometimes concerning heart condition called Wolff-Parkinson-White syndrome, or WBU. We'll explore what causes it, how it affects the heart, how it's diagnosed, and what treatment options are available. So, let's get started on understanding UPW. Let's talk about what causes WPU. In most cases, UPU is present at birth, meaning it's congenital. It's typically caused by an extra electrical pathway in the heart. Normally, electrical signals travel from the heart's upper chambers, the atria, to the lower chambers, the ventricles, through the atrioventricular, or AV node. In WPU, accessory pathway, often called the bundle of Kent, allows electrical signals to bypass the AV node and reach the ventricles faster. While most cases are spontaneous, meaning they aren't inherited, some individuals may have WPW as part of a genetic syndrome, though this is rare. To really understand WPW, we need to discuss its pathophysiology. Imagine your heart's electrical system as a carefully orchestrated network of roads. The AV node acts like a toll booth, slowing down the electrical signals to allow the atria to contract fully before the ventricles. In WPU, the accessory pathway is like a shortcut, bypassing the toll booth. This premature activation of the ventricles, before the signal has properly passed through the AV node, leads to a specific pattern on an EKG called a delta wave. This abnormal electrical activity can trigger episodes of rapid heart rate, known as supraventricular tachycardia or SVT. The heart is essentially being told to beat too quickly, and sometimes irregularly, due to these conflicting electrical signals. Now, let's look at how common WPU is relatively rare. It's estimated to affect between 0.1 and 0.3% of the population. That means about 1 to 3 people out of every 1,000 might have UPW. It's usually diagnosed in children or young adults, but it can sometimes be discovered later in life during a routine medical examination or after an episode of rapid heart rate. What are the signs and symptoms of WPU? Many people with WPU may not experience any symptoms at all. However, when symptoms do occur, they are usually related to episodes of rapid heart rate. These can include a sensation of a racing or pounding heart, known as palpitations. Other symptoms might be dizziness, lightheadedness, shortness of breath, chest pain or discomfort, fainting, and, in rare cases, cardiac arrest. The frequency and severity of these symptoms can vary greatly from person to person. So, how is WPU diagnosed? The primary diagnostic tool for WPU is an electrocardiogram, or EKG. An EKG records the electrical activity of the heart and can detect the characteristic delta wave pattern associated with WPU. During an episode of rapid heart rate, an EKG can confirm the presence of SVT. In some cases, additional tests may be needed, such as an electrophysiology study, or EPS. This involves threading thin, flexible wires through blood vessels to the heart to map the electrical pathways and pinpoint the location of the accessory pathway. While WPU is a single condition, the presentation and risk can vary. Some individuals might have a concealed, accessory pathway that only becomes apparent during episodes of rapid heart rate. Others may have multiple accessory pathways. The risk of developing life-threatening arrhythmias, such as atrial fibrillation with rapid ventricular response, can also vary. Doctors will use various assessments, including the presence of pre-excitation during exercise, or the presence of multiple accessory pathways, to predict the severity of the condition. When it comes to treatment and management, the approach depends on the severity of symptoms and the risk of complications. For those with infrequent or mild symptoms, observation may be sufficient. However, for individuals with more frequent or severe episodes of rapid heart rate, treatment options include medications to slow down the heart rate or to prevent episodes of SVT. A more definitive treatment is catheter ablation. This minimally invasive procedure involves threading a catheter to the heart and using radiofrequency energy to destroy the accessory pathway, essentially eliminating the shortcut. Unfortunately, there's no specific way to prevent WPW since it's usually a congenital condition. However, understanding your individual risk factors and managing any underlying heart conditions can be beneficial. If you have a family history of WPW or experience any symptoms suggestive of rapid heart rate, it's important to talk to your doctor for evaluation and guidance. The prognosis for individuals with WPU is generally good, especially with appropriate diagnosis and treatment. Catheter ablation is highly effective in curing WPW with a success rate of over 90%. Researchers are continuously exploring ways to refine ablation techniques and improve outcomes. There is ongoing work to improve non-invasive mapping of accessory pathway locations, potentially reducing the need for invasive electrophysiology studies. Research also continues to focus on identifying the genetic factors that may contribute to WPW in rare familial cases. Ultimately, early detection and management are key to ensuring a positive outlook for those living with WPW. Thanks for joining us on this journey to understand Wolff-Parkinson-White syndrome.